Okay, our next topic that we're going to cover is drugs of abuse. So, before we dig into drugs of abuse, I feel it's important to kind of have an outline because there is a whole bunch of them, and I wanted to break it down into categories because that helps organize it a little bit better. It's really important to know the symptoms of each drug and the treatment for each overdose and withdrawal. So remember that you have to treat the overdose, but you also have to treat the withdrawal. So when we talk about drugs of abuse, they're broken down into three different categories. The first category is depressants, opioids, barbiturates, and benzodiazepines. And when I talk about barbiturates, drugs like phenobarbital is the classic one. Benzodiazepines, we all know about them, alprazolam, lorazepam, things like that. Uh, and then in the category of depressants, alcohol falls in that category as well, but I didn't mention it because it has its own separate lecture. Stimulants is the second category. So these are medications that stimulate the nervous system, amphetamines, cocaine, and nicotine. Um, are drugs in these categories. And then the last category is hallucinogens. So these are drugs like phenylcyclopentadiene, PCP, or LSD, marijuana, and MDMA or ecstasy. So um, as we go through these drugs, kind of keep the outline in your mind. And my uh, oh, there it goes. It was just stuck in that slide. So the first category of drugs that we're going to talk about is depressants, and the first drug in that category is opioids. And one of the classic drugs of abuse is heroin. Heroin, I don't have it here in a slide, but just a fun fact, it's called diacetyl morphine, and it's literally just two morphine molecules stuck to each other. It's very fast acting, works very quickly, so it has a very fast onset of action. So overdose of heroin or opioids in general is very classic. So you get euphoria, but the classic ones are respiratory depression, CNS depression, and pinpoint pupils. So this is like the triad. It's very important to recognize this triad. And I think the most one that kind of will pop up on the test, they'll give you all of this, but it's really important to understand the pinpoint pupils. And why do patients that abuse opioids get pinpoint pupils, or patients that use opioids in general? So if you remember, the pupils is controlled by two muscles, muscle that constricts and the muscle that dilates. The muscle that constricts is controlled by parasympathetic nervous system or acetylcholine because, you're constricting, you don't want that much light going in because, it's parasympathetic, it's rest and digest. And then the other muscle is the sympathetic one that's controlled by norepinephrine. So if you think of it, opioids activate um, the parasympathetic uh, nervous system and cause constrictions of the pinpoint. So that's what of overdose is very important and very high yield is naloxone. And I believe Mike spoke to you about naloxone. So that's overdose. For withdrawal, so withdrawal happens when you are constantly using opioids and you stop. And withdrawal is you get flu-like symptoms, so sweating, rhinorrhea, runny nose, diarrhea. Distinct that you'll kind of see on the exam is that you'll get piloerection. The hair kind of stands and dilated pupils. So if you think of these are the opposite of the parasympathetic system effect. These are more sympathetic nervous system effect, dilated pupils and piloerection. Treatment of withdrawal is multimodal. So you can replace the opioids using drugs like methadone or buprenorphine. Methadone is long acting, buprenorphine is a little bit shorter acting. You can reduce the relapses using naltrexone, and these drugs already, Mike, I believe, spoke to you about it. And then you can use symptomatic treatment like benzodiazepines, clonidine, which is an alpha 2 agonist because it decreases norepinephrine and glutamate release, and loperamide, which is an antidiarrhea because you remember that patients get diarrhea for opioids. And just fun fact: do you know why patients get diarrhea from opioid withdrawal? So, if you remember to the physiology of opioids, there's opioid receptors in your GI tract, and these cause constipation, right? So, if you withdraw opioids, these receptors are not going to be stimulated anymore, and you'll get kind of like a prokinetic effect, and you get diarrhea. Next drugs in the depressant category is the barbiturates. Barbiturates are kind of dangerous medications to overdose on because overdose can cause respiratory depression and hypotension, and the margin of safety is actually much smaller for barbiturates. So you can overdose on a very small dose of barbiturates. Treatment is supportive. Withdrawal barbiturates cause cardiovascular collapse and delirium, and also treatment is supportive. Third medications are benzodiazepines. So overdose cause ataxia, minor respiratory depression. But remember, you don't get hypotension like when you get into barbiturates, and you don't get pinpoint pupils like when you get with the opioids. So all of these depressants, they depress the respiratory centers, but each one has distinct characteristics. This one causes pinpoint pupil, this one causes hypotension, and this one causes ataxia. Treatment for benzodiazepine overdose is flumazenil. Flumazenil is a benzodiazepine antagonist. However, the biggest thing with flumazenil is that it can precipitate seizures. And the reason for that is benzodiazepine are anti-epileptic, right? Because they facilitate GABA agonism, and GABA is an inhibitory. So if you block that, you can cause excitation in the nervous system and you can precipitate seizures. Withdrawal of benzodiazepines, you can again get seizures, depression, anxiety. Treatment for it is detoxification, is you can do gradual dose reduction of the benzodiazepine. You can also use a long-acting benzodiazepine because of the long half-life, it has less likelihood of withdrawal, and you can use medication like phenobarbital or carbamazepine. Next category of drugs are stimulants, and stimulants have, just one major idea is that they increase norepinephrine in the CNS and sometimes in the periphery too, and they stimulate everything. So for amphetamines, overdose is uh, how you recognize is that patients are like super hyper. They have prolonged wakefulness, you have mood elevation, you have hypertension because the norepinephrine, and you get tachycardia. And all of these is because of high norepinephrine. What's also important to understand is that you also get pupillary dilation, and we explained that because norepinephrine gets released, goes to the sympathetic receptors that can, and I forgot which one exactly, but you can review the physiology of the eye, but it causes dilation of the pupils. You can also get seizures from amphetamines overdose, and you can get cardiac arrest because uh, if when you get massive release of norepinephrine, it causes so much stimulations of the beta receptors on the heart, and it can lead to arrest. Treatment is benzodiazepines for seizures and agitation. Withdrawal is that you're taking all that norepinephrine that you kind of gave, so you get a post-use crash, depression, and sleep. So it's the opposite of the overdose. I apologize. Cocaine is um, cocaine overdose is pretty much the same as amphetamines in addition to a few other things. So you get pupillary dilation, you get mood elevation, but you also get hallucinations. With amphetamines, you don't get hallucinations, and you also get paranoid ideation and angina. And angina is also related to the cardiac effects of norepinephrine. Treatment for cocaine overdose is for overstimulation, you can give benzodiazepines and antipsychotics. For the hypertension, sorry, I failed to mention that overdose of cocaine also causes hypertension. Because of the norepinephrine release. For hypertension, we use alpha 1 blockers, and we want to avoid beta blockers. Now, can you guys tell me why we use alpha 1 blockers and not beta blockers? So the concept is this: the norepinephrine goes everywhere. It goes to the heart and then goes to the vasculature. Alpha one receptors are in the vasculatures, and beta receptors are on the heart, or at least beta one is in the heart. If you give alpha blockers, then you're going to block this vasoconstriction in the vasculature and you'll be fine. You'll treat the hypertension. But if you give beta blockers by itself, think about what's going to happen. The norepinephrine is going to going in its way, and it wants to stimulate the heart, but it's going to be antagonized by the beta blockers on the heart, so it's not going to work in the heart. But it will go to the vasculature and it will cause severe vasoconstriction of the vasculature. And we call that unopposed alpha effect because the alpha receptors are very stimulated. And you get severe vasoconstrictions, severe hypertension, and you can also get some limb ischemia because the vasculature is so constricted. So that's why we want to avoid beta blockers. Withdrawal of cocaine is the same as amphetamines. Third drug in the stimulants is nicotine. So nicotine's general characteristics is it works on the nicotine acetylcholine receptor. It's an agonist, has rapid tolerance, you get strong withdrawal syndrome, and you have very high relapse rate. Overdose of nicotine, you just get restlessness. Treatment is decontamination and treatment of the symptoms. Withdrawal is irritability. Treatment is you can replace it using nicotine patches, gum, or lozenges. Bupropion, which is works in acetylcholine receptor. It's an acetylcholine receptor agonist, and varenicline, which is Chantix. It's also a partial agonist. I don't think varenicline is in your lecture, and I don't think we've talked about it yet, but it's in first aid, and I think it comes up on questions. Varenicline is a partial agonist for nicotine. So we talked about stimulants, we talked about depressants. The third thing that we're going to talk about is hallucinogens. And the general idea of hallucinogens is that they cause release of central nervous system neurotransmitters that cause these hallucinations. Um, so PCP is the first drug that we're going to talk about. How it works is that it's an NMDA and glutamate receptor antagonist. Um, so overdose for PCP, and it's really important to know this, is that patients kind of like become like Superman or Superwoman. They have violence, they have extraordinary physical strength, they get seizures, but the really key point, or like the high yield point that you have to know for PCP, is that they get vertical nystagmus. Their eyes kind of keep going up and down from PCP. Treatment is benzodiazepines or fast-acting antipsychotics like haloperidol. And there's no really withdrawal symptoms for PCP. LSD is another hallucinogen. Um, and the mechanism of action is that it's a serotonin agonist. Overdose for LSD is that you get depersonalization, perceptual distortion. Kind of everything becomes like a 3D space, either visual or auditory perceptual distortion. Withdrawal is none for LSD. Um, the third medication in our hallucinogens is cannabinoid, which is marijuana. How it works is that it activates the cannabinoid receptors. Overdose of cannabinoid is, and this is high key for exams, is that you get perception of slow time, increased appetite, and the really, really important one is conjunctival injection. So the eyes get kind of red. Withdrawal is irritability, anxiety, and decreased appetite. And people have made use of this increased appetite to make a pharmacological form of marijuana called dronabinol, and it's used an appetite stimulant in AIDS and cancer patients. The last hallucinogen we're going to talk about is MDMA or ecstasy. How it works is that it releases serotonin, norepinephrine, and dopamine. Um, Overdose for MDMA, you get hallucinations, disinhibition, distorted sensory and time perception, and these are kind of similar to LSD. Uh, but for MDMA, the kind of the key one is that you get teeth clenching, and that's specific to MDMA. You also get autonomic effects from the MDMA because you're releasing norepinephrine and dopamine, which are vasoactive substances. So you get hypertension, tachycardia, and hyperthermia. Treatment for MDMA is also benzodiazepines and dantrolene if there's hyperthermia. I'm not sure if we have spoken about dantrolene before or not, but it's a medication that is used to treat malignant hyperthermia. If Mike haven't spoken about it yet, then we will get a chance to speak about it. But I want you to know that dantrolene is used for hyperthermia. Withdrawal for MDMA is that you get depression. A lot of things that kind of go together in the drugs of abuse, but if you know the key symptoms, you'll be able to recognize the the drug that is abused and be able to treat it. So that concludes our section in the drugs of abuse, and next we're going to be talking about ethanol. Okay, guys, welcome back, and this is our last discussion of this review session, and we're going to discuss alcohol. Um, so, um, as you remember from biochemistry, alcohol is discussed a lot of biochemistry, but today we're going to be discussing the pharmacological effect of alcohol and the pharmacology behind alcohol withdrawal and alcohol use disorder. So, I guess we're going to start with the metabolism of alcohol. And alcohol is metabolized by alcohol dehydrogenase using NAD plus as a cofactor. It makes NADH. And when alcohol is metabolized, makes acetaldehyde. Acetaldehyde is then metabolized to acetaldehyde dehydrogenase using also NAD plus to make acetate. So we can make use of this metabolism by inhibiting either this enzyme or this enzyme, or they get naturally inhibited. Acetaldehyde, when it accumulates because of acetaldehyde dehydrogenase, causes the hangover symptoms, and that's what we call the disulfiram reactions. So there's a lot of drugs, for example, that cause this, and one of them is what? So metronidazole. Metronidazole is a medication that causes acetaldehyde dehydrogenase inhibition. So when you give alcohol or when patients take alcohol, you end up accumulating acetaldehyde and causes hangover. So a little bit about alcohol as far as pharmacology. So alcohol is a zero order kinetics. And do you guys remember way back from when we first started M2 year, what is zero order kinetics? Yes, so zero order kinetics is a constant rate of elimination, meaning if you started with a certain dose, the rate that this medication is going to get eliminated is constant. So I'll give you an example. Let's say you started with 200 milligrams of ethanol. Uh, that you ingested, and the rate of elimination is, let's say, 50 milligrams per deciliters. By the first hour, you're going to eliminate this 50 milligrams, so you're going to have 150 left. The second hour, you're going to eliminate another 50, so you're going to have 100 left, and so on and so forth. So that is called zero order kinetics because it's the rate of elimination is constant. Do you guys remember what other medications or drugs have zero order kinetics? So aspirin is one of them. It's a really important one, and phenobarbital. And the reason why I harp on this so much is because test examiners love to test that fact because it's very important. So alcohol has zero order kinetics. How does alcohol work? It stimulates GABA A, so it leads to inhibition. Also inhibits glutamate and NMDA receptors. There's a lot of effects of chronic alcohol use, liver effect, GI, and CNS. So liver, you get fatty liver, you get alcoholic hepatitis, and you get liver cirrhosis. GI, alcohol is an irritant, so it causes gastritis, esophagitis, peptic ulcer disease, and pancreatitis. And CNS is a depressant, so it causes CNS depression and dependence, peripheral neuropathy, Wernicke, and dementia. Mothers who use alcohol during their pregnancy can have their children can have fetal alcohol syndrome, and it's the leading cause of mental retardation. So fetal alcohol syndrome, mental retardation. Also, you have reduced birth rate and growth retardation, and it's dose dependent. There's a bunch of drug interactions for alcohol. I guess the ones that I wanted to focus on is a few different ones. First thing is that because alcohol is a depressant, it's a CNS depressant. If you combine it with another CNS depressant, there is an enhanced or synergistic effect. So, for example, if you combine it with sedatives like phenobarbital or benzodiazepines, or hypnotics like zolpidem, or opioids, you have a higher likelihood of CNS depression, respiratory depression. Uh, Second thing with alcohol is that you get the alcohol flush reaction, the one that I talked about earlier, and it's a disulfiram reaction, and it's because of inhibition of alcohol dehydrogenase. So alcohol dehydrogenase gets inhibited here. You get a accumulation of acetaldehyde, and that causes the hangover symptoms. Medications that cause it is metronidazole is the biggest classic one that you'll see in exams, cephalosporins, and there's a medication also called disulfiram that we're going to talk about later. It's used to deter people with alcohol use disorder from um, from using alcohol. And the last thing that I was going to talk about for drug interactions is that alcohol can cause rapid drug metabolism. And the reason for that is alcohol causes stimulation of the CYP enzyme. So medications that are metabolized by the CYP enzymes, like phenytoin, barbiturates, or acetaminophen, are metabolized rapidly. Now, what does this mean? It means that you're going to need higher dose, for example, for phenytoin or barbiturates, but for acetaminophen specifically, if you combine it with alcohol, you get hepatotoxic metabolites. And the reason for that is that you increase the CYP metabolism of acetaminophen. Acetaminophen, as we know, gets metabolized into reactive oxygen species that have to be combined with glutathione to be excreted safely, but the body can't handle this fast rate of metabolism, so you get hepatotoxic metabolites and you get liver failure. Um, so that's just a general overview of alcohol. Now we're going to talk about alcohol intoxication. So, I guess the one thing that I wanted to talk about alcohol intoxication is hypoglycemia. And hypoglycemia is important to recognize on the test because of the biochemistry behind it. And I'm not going to go into depth behind the biochemistry, but know that oxidation of alcohol produces 2-NADH, and that favors pyruvate to lactate metabolism instead of glucose for gluconeogenesis. So you get hypoglycemia with alcohol. The second thing that I wanted to talk about is the symptoms according to the blood alcohol level. And Dr. Snyder likes to test at what symptom you will, at what level you will get what symptom. And she'll give you this percentage. So the conversion is 0.08%, is pretty much 80 milligrams per deciliter. Um, in the blood alcohol level or blood alcohol concentration. So she'll give you that percentage and she'll ask you what symptoms is the patient going to get. So 20 to 50 you get relief of anxiety and euphoria. 60 to 100 you get more CNS symptoms, so slurred speech, ataxia, impaired judgment, and aggressive behavior. 200 to 250 is sedation. 300 is loss of consciousness, and 400 to 500 is coma, respiratory paralysis, and death. So we talked about alcohol intoxication. Now we need to talk about alcohol withdrawal. So the problem with alcohol withdrawal is that we know that alcohol stimulates GABA, so it causes inhibition of the CNS. So alcohol withdrawal is the opposite of that, is too little GABA. Or you can also get too much glutamate because alcohol or ethanol inhibits glutamate. So glutamate is an excitatory neurotransmitter. So in alcohol withdrawal, think of it as too much excitation. This is a very helpful timeline from first aid, and you'll see it on exams too, that examiners, they'll ask you, patient last drink was, I don't know, 5 o'clock this morning, and right now it's about 10 p.m. What symptoms is patient gonna get? Or the patient is having this and this symptoms. When do you think their last drink was? And actually it comes useful into clinical practice. So 3 to 36 hours from the last drink, you get anxiety. 6 to 48 hours, you get the withdrawal seizures. Um, and I remember I got pimped by my medicine attending about this and I didn't know it. So now you know it. 6 to 48 hours, you get withdrawal seizures. 12 to 48 hours, you get hallucinations, and 48 to 96 hours, you get delirium tremens. And delirium tremens, you learn about it uh, in pathology, I believe, but it's this hyperstimulation of the autonomic nervous system. So you get like a sympathetic overdrive. So you get hypertension and tachycardia, and it can be very dangerous. Treatment of alcohol withdrawal is IV fluids because these patients tend to be dehydrated. Second thing is that you give thiamine first, then glucose. And the reason for that is to decrease the risk of Wernicke encephalopathy and to decrease the risk of hypoglycemia. Third, which is pretty much the cornerstone of treatment, you give benzodiazepines, and that's just to stimulate GABA. Beta blockers have been used for the tachycardia, and clonidine also for sweating or tremors. This is not going to be an exam, but just an interesting thing to be aware of. Gabapentin has also been used recently for alcohol withdrawal, and the idea behind that is that it stimulates the GABA receptors, and it's been found to actually reduce the rate of recurrences for alcohol withdrawal. Next syndrome that we're going to talk about is Visalgia or hangover. Again, like I talked about, the mechanism or the reason for that is because you have increased acetaldehyde because of the inhibition of acetaldehyde dehydrogenase. Patients are usually dehydrated. Treatment is to replace fluids, give NSAIDs, and give vitamin B6. And lastly, last alcohol syndrome that we're going to talk about is alcohol use disorder, and this is a form of addiction. And please don't call it alcoholism or don't call your patient alcoholic, and because I guess it's a negative connotation. So the new terminology is alcohol use disorder. And I'm not going to talk too much about the disorder itself, but I'm going to talk about the pharmacology that is used in alcohol use disorder. So the biggest thing with alcohol use disorder is that I want to reduce patient use of alcohol. Now I can do that in different ways. I can discourage the patient from using alcohol. I can reduce, the craving, or I can increase their days of abstinence. So the first medication that we can use in alcohol use disorder is disulfiram. So it's very, very important to know how this drug works. So this drug inhibits alcohol dehydrogenase. So uh, you get a very severe flush reaction when patients use alcohol. The problem with the idea behind disulfiram is that patients take it and they're not supposed to drink because they know they will get very bad flush reaction and hangover. The problem is it's not very effective in abstinence because patients know this, and if they want to drink alcohol, the craving is strong enough that they'll just stop taking the medication. So this medication has kind of fallen out of favor. It's not very effective. The truly effective medication is naltrexone. So if you remember, what is naltrexone? Naltrexone is pretty much the oral form of naloxone. And what are these medications do? These are opioid antagonists. And you're going to ask me, well, why are you using opioid antagonist for alcohol? And I'll tell you, I don't know. But it has been shown that naltrexone uh, reduces the craving and relapse rate. So it's really, really important. There's a couple of questions in New World that will ask you. There's a patient that's using medication to use craving. What is the mechanism of action for that medication? And the mechanism of action is an opioid antagonist. It's not inhibition of alcohol dehydrogenase, but it's an opioid antagonist, specifically a mu opioid antagonist. Next medication is called acamprosate, and how it works is that it reduced hyperexcitability of NMDA. It increases abstinence and no effect on craving. It's a low yield drug. Topiramate has also been used because it facilitates GABA function. It has been found to reduce the number of drinks and increase days of abstinence. The two drugs that I want you guys to know about is naltrexone and disulfiram. And I also want you to be aware of this timeline and be aware of the general treatment of the alcohol withdrawal. Now, lastly, that we're going to talk about is other alcohol besides ethanol. And other alcohols become very, very important because A, they're high yield in exams because they're kind of unique, and then B, you have to recognize how to treat it. So the first thing that patients can abuse is methanol. Methanol is metabolized into formaldehyde and formic acid, which is very, very toxic. The symptoms for methanol is uh, you get metabolic acidosis. And let me ask you a question. Do you get anion gap metabolic acidosis or non-anion gap metabolic acidosis? So the answer is you get anion gap metabolic acidosis because it is an acid. So the acid kind of goes in, how I think about it is goes in, buffers the bicarbonate that's in the blood. So you get an anion gap. Your gap, like your anions are missing because you're using that bicarbonate. So you get anion gap metabolic acidosis. You get coma, respiratory failure. The biggest thing to know for methanol and how you'll differentiate it is that you'll get optic nerve damage from the methanol. So that's a high yield point. Ethylene glycol is also an important one to be aware of. It has a sweet taste, so it's dangerous for children or pets, so they can use it. Metabolites is glyceraldehyde, glycolic acid, and oxalic acid. So really, oxalic acid is the one that is really problematic because oxalic acid, as you know, can go to the kidneys and concentrate as an oxalic acid stones. So you get renal failure because of oxalate deposits. You also get anion gap metabolic acidosis with ethylene glycol. So very, very important to know this. And how the questions in the test will come is that you have a patient who's coming in and he's in respiratory failure or in coma, and you get an ABG and you found that he's acidotic, and you'll find that he has metabolic acidosis, and you'll find that it actually has anion gap metabolic acidosis. And they'll ask you, well, uh, what is the drug or what is the patient most likely abusing. If patient has optic nerve damage, then most likely it's methanol. If patients have oxalate deposits or you have any hint of renal failure, then it's ethylene glycol. And with methanol, you don't necessarily have to get optic nerve damage. It just, it's a distinctive characteristic. So it's very important to know the difference between these two. Treatment for methanol and ethylene glycol, first is that you have to treat the acidosis. So you give sodium bicarbonate IV. The second thing that I would like you guys to be aware of is fomepizole. So um, how does fomepizole work? So fomepizole is an alcohol dehydrogenase inhibitor. And you're going to ask me, well, why do I want to inhibit alcohol dehydrogenase? Remember, the toxicity for the methanol and the ethylene glycol is from the metabolites. So methanol and ethylene glycol have to be metabolized first into by alcohol dehydrogenase into these toxic metabolites. So if I am able to inhibit that first enzyme that metabolizes, which is alcohol dehydrogenase, then I'm able to bypass the effect of the toxic metabolites. So fomepizole is a first line for the treatment of methanol and ethylene glycol abuse. Um, if fomepizole is not available, we can actually use ethanol. So we can use alcohol to give the patient. You're going to tell me, well, that's not ethical. How am I going to give patients alcohol? Well, I'm going to tell you that, it saves their life. And the reason for that is because ethanol, if you give ethanol along, if patients have abused these other alcohols, that it saturates the alcohol dehydrogenase. So it goes and competes with these other alcohols and it prevents toxic metabolites. Of course, ethanol is a second line if no fomepizole is available. Last ditch effort is dialysis, and that's mechanically removing ethylene glycol or methanol from the blood in its last line. So that concludes our discussion of ethanol. I know that was a lot to cover. But take a minute to kind of digest all of these things. And I know that Mike kind of gave you guys his step one spiel in the beginning, but I wanted to encourage you guys and wanted to let you know that as important as step one is, and everyone harps about it, you are also important. So take a moment for yourself, take some time for yourself to kind of absorb, all of these material that's being thrown at you, but realize that you're also important, and you're actually more important than your step one grade. With that, I wish you guys the best in your studies. If you have any questions regarding pharmacology or even step on studying, please don't hesitate to reach out to me or to Mike. Thank you.